Welcome to our University of Tokyo Medical Education Seminar. This is the 97th of Medical Education Seminar year. 96th Medical Education Seminar. And we welcome Professor Linda Snell. And today's topic is future directions in medical education, designing and delivering innovative curricula. This is the second lecture of 4 consecutive lectures of new direction of medical education. So let's welcome Professor Linda Snell.
Can I please stay for another 2 months? The reason I want to stay for another 2 months is then I get to do the 100.
Yeah.
Or maybe I'll do another 2 lectures. So that would be nice. So welcome back, everybody, and thank you for coming back. I know people can come to the first lecture because they don't know what the lecture is going to be like, but if you come back, it shows a lot of confidence. So thank you very much. As Oni-sensei said, this is part of a 4-lecture series on what's new in medical education, both in terms of curricular models of teaching and learning and assessment and evaluation. And I'm giving these lectures using some examples that I know that we've been working with at McGill and in Canada. And I hope that these things stimulate you to think about how the Japanese medical education system could change. So this is the second lecture on designing and delivering innovative curricula. But I'd like to remind you for a second what we talked about last month, because it does apply to this. I shouldn't say we, I propose that our current models have problems and that we need to change, and that there are some newer paradigms of medical education, including competency-based education, which this works, which are being implemented globally and may well be able to address some of the challenges that we've had. And I did make a couple of proposals for things that could be done within Japan that might actually help move things forward, as it needs to be done all over the world. These were some of the proposals I made. Develop a competency framework, sequence them, and we're talking about these a little bit more today in detail, and reconsider how you assess trainees. Before we start though, I'd like to ask you a question. And what I'd like you to do is work in pairs with the person beside you or in front of or behind you. And I'd like you to talk to each other and think about how you would design an education system or a curriculum that would produce graduates that were not prepared for practice. Okay, the opposite of what we're trying to do, right? How would you try and develop medical education so it didn't work, in other words? And I'd like you to do that, because then we can talk about the opposite, obviously. So spend maybe a minute or 2 talking to your neighbor about developing an ineffective medical education system. If you're not sitting next to someone, look in front or behind you. Go ahead, please. You can work in 3s too. Side or behind you. Do you need a little more time, or have you got a system developed? Okay. Well, that was an interestingly lively discussion. As I walked around, I heard some interesting ideas. I'd like to hear some of those ideas. Would anyone like to volunteer an idea of how they would develop an ineffective medical education system? Kozu Sensei, I know you've got lots of ideas.
If we have education totally done by what goes to lectures,
Okay.
that would be
Sure, lectures. Okay, thank you very much. Anyone else have any other ways that they think they could have an ineffective system? Takeda Sensei.
Right. So lectures, providing just the knowledge and assist them based on what they memorize, and do not let them think through the reasoning.
Sure, so basically rote memorization during lectures, and that's as a requirement for assessment, as opposed to developing that and applying that to reasoning and other processes.
Make sure they don't need any patients.
Make sure they don't meet patients. Sure. Okay, thank you very much. If they did that in nursing school, I don't think we'd be very lucky. Any other suggestions? Chris?
Make sure the lectures are 4 hours long.
Oh, 4-hour lectures.
That's not yet.
Okay.
no feedback.
No feedback. Ah, okay, great. Thank you very much. Any others? Come on, you were all talking, so I know you had things in your mind. Gentlemen? Wait a second, Chris.
I'm from US. I was in the terms about muscle or bone.
Yeah.
So I felt it was very ineffective.
So even when you were in your physiotherapy school, memorizing stuff like anatomy wasn't very effective. Okay, good. I'll take one more. Any sensei?
Okay. That learning critical stuff only and no basic science.
Okay, so this one was going to the other thing, having learning without clinical stuff without basic science. I think Osler had a saying for that. William Osler. Learning medicine without seeing patients. What is it? Learning medicine. Something about going to see. So if you learn medicine from books, Chris, do you remember it?
I don't know which is which, but going out to see without charts.
Yeah. So I know what it was. Learning medicine without books is like going to see without charts, but learning medicine from books and not patients is like not going to see at all. I thought that was a really good saying. Yeah. So this is the medical school from hell, right? Is that we're talking about the medical school, which is not effective, and yet when we think about curricula, including some of the curricula that we have as students and residents, and some of the curricula that still exist, some of those things still happen, and many, many more things too. So there's probably, it means that there's a time to change. So here's what I'm going to be talking about over the next 4 hours of lecture. No, over the next 3/4 of an hour or so. A little bit more about competency frameworks, a stepwise approach to curricula, how you go about defining curricular goals using the abilities of the graduate as a framework, and then mapping progression towards that, sequencing teaching and learning within that, and a little bit about some innovative teaching and learning strategies that we've used at McGill to try and push this forward. And then I am again going to very rudely propose, shall I say, that there are some things that might apply here in Japan. So this is what we're talking about, and it actually does fit a model, that Kern's curricular cycle model, which has been slightly adapted here. Really, we've said start off with the end in mind. Start off with what you want the graduate to look like, to be like, his abilities or her abilities. Find out where they are, and then you'll have what they need to know and can develop learning objectives, do some teaching, assess, and evaluate the program to see whether you are where you think you should be. In fact, these days we often talk about abilities rather than needs, and we often talk about competencies or outcomes. But it all fits into this systematic educational planning, and we can't forget that context, culture, the learning environment, all of those things are really important and influence curriculum. Today, we're really only going to be talking about this part here. And in fact, what we're going to be doing is talking about developing or planning a curriculum and a few ways that you can implement interesting teaching. So let's start off with some of the comments about planning. It's something that's done in a stepwise approach. I feel that we should develop curriculum based on some goals about what we want the person to be when they get out and they're graduating and they're our doctor. I mentioned this the last time. And I was surprised that none of you mentioned, as part of your ineffective medical school, training people without actually having a goal or an outcome that was appropriate or useful to society. The steps include defining not only what the goal is, but the steps along towards that goal. And then fitting in the teaching and learning experiences. So we're going to talk a little bit more about that. But before we do, I'm going to review a couple of definitions we talked about last time and add a couple more. You may have heard of some of these before. I believe that Mary Lee, who was here giving this lecture in October, also mentioned a couple of these in a slightly different context. So the first is competence, which has been defined as the array of abilities which includes knowledge and skills and attitudes and behaviors across many domains or aspects of performance in context. We'll talk about the in context. That means that there have to be qualifiers. It's not just that I'm a competent physician, it's that I'm competent as a communicator, or I'm competent to practice in a teaching hospital in Montreal, but perhaps not in a community hospital in a third world or in an underdeveloped country. And it can change over time. It can change with the kind of patients, the kind of environment, what I had for breakfast or how much I slept, all of those things. And it can also change with experience. Now, Mary Lee used a description from Dr. Sklar, who's the editor of Academic Medicine, who described competence as a global, general impression of the ability to practice independently. And that's what we want, somebody to be able to practice independently, safely, and competently. A competency, which is part of competence, is actually one ability that you can observe and that integrates all of those knowledge, skills, and attitudes. And I'll give you some examples of that. So it's an area of performance that you can see and describe and measure. And that becomes important for educators. They can be put together like building blocks. And when they're put together, eventually you have competence as opposed to a competency. I thought I had examples there. Yes, I didn't. We also talk about domains of competence, which is really a description of the global abilities needed by any health professional, a physiotherapist, a nurse. I use CAMMEDS, which was nicely republished in 2015. And there are 7 roles, which are really almost like meta competencies. They're things like professional, collaborator, etc. So a domain of competence would be something like communicator or professional. It's a big thing in which are competencies, and then they can be broken down even further. If you look at competency-based medical education, but frankly, I think if you look at any education that we do as health professionals, we can use those concepts to help guide our curricular planning. We start with the competencies needed for practice. Those then drive our curriculum planning, our assessment planning, and the way that we teach and learn. So they're really at the center. It's not like we start with an objective, like learn 1,000 facts, or the anatomy of the leg, or something like that. We start with, what is it that the individual will have to do in practice? And Oni Sensei and I had fun the other day talking to some public health doctors who are considering developing a competency-based public health training program. And first question I asked was, what do public health doctors do? Not what do they need to know, but what do they do? Because that can then start to develop the competencies needed in practice. So as I said, the competencies drive these things. So in curriculum, they will drive what kind of learning experiences you put into the curriculum, what kind of sequencing of learning you do. In learning, you also want them to be learning in the actual setting. You want them to be in the clinical setting. And you want to have clearly defined outcomes. And we'll talk about that in a minute. The teaching should be focused on the learner. It should be learner-centered. It should be individualized. Not every learner learns the same thing at the same pace. And we won't talk about assessment now, but get rid of that. We will talk about that next time. So, we have to identify the graduate abilities, and I mentioned last time how we did that with CanMeds. We can then, once we have those graduate abilities, use them as the base of the curriculum goals. But that's the end. We were there and we're over here. So we have to, in some way, map how we get from here to there. That becomes the progression of competence. And let me give you an example, again from Canada, of how we do this in residency education. This is done in all residencies. Now, here, and certainly when I went through residency, you were a postgraduate year 1, and then 2, and then 3, and then 4, and then whatever, and then you're out. Okay, it's by numbers. You maybe had a name, junior resident or senior resident. Now, we have some different names. They're not years because sometimes they take less than a year, and sometimes they may have variable time. That one's probably not seen very well. It says transition to discipline. That's when the resident comes in from wherever, a medical school across Canada or somewhere around the world, and we want to make sure that they're appropriately oriented, that they have the basics, that they can do most of the things that we expect a resident on day 1 to do. That's a relatively short time. It may be a few weeks or it may be a few months. And for some people it may take longer than others. For instance, our international medical graduates who come in, we actually have them do an orientation course before residency starts, so that they the English expression is hits the ground running. The foundation level stage of residency is where the broad competencies are covered. Every trainee must have these before they move on to very discipline-specific activities. So this would be somewhat what we would expect in the old terms, a junior resident or an intern to do. And then the core of stage is often a few years, and that's where you get the basics of whatever the discipline or specialty is. And here's an important one that we never had before, transition into practice. You know, one day you're a resident and the next day you're out there in practice. And the day after that you go, oh, I don't know that, I didn't learn that in residency. And in fact, I've had some of our junior faculty members come and talk to residents about what I didn't know when I went out into practice that I needed to know. And it can be anything from setting up an office, to hiring a secretary, to figuring out how to continue to learn when nobody's forcing you to do it, to the new things that come along that you need to know. We've diagrammed what I've just talked about in this diagram, which you could probably see better on your handout. Here it starts off with medical school at the bottom, and those 4 stages: transition to discipline, foundations, core, transition to practice, and then a great big area here, which is learning in practice or continuing professional development. It's big because this may take a few years, probably less than a decade, and this may take 3 decades. And then we realized there was also a transition out of practice, which people haven't explored very much, including us in Canada. So the traditional phases were intern, junior, resident, senior, practicing physician. The new phases are basically discipline-specific residency and learning in practice. Why are we even talking about this? Because there is progression of competence. And it's not like I can put you on an inpatient surgical service on day 1 of your residency or day 750 of your residency and expect that you'll get the same thing out of it. The idea would be that there are things that can be done in sequence so that you develop appropriately to the level that's needed for practice. And for each of the competencies, there's a spectrum from novice to expert. And we want somebody to be at least competent, which is slightly less than expert, before they get out into practice. And as mentioned, at any given time, in any given context, you'll be more or less, you'll have more or less ability. But the idea is to progress along to competence in all abilities before you are released on the public. To use that, we use this thing called milestones. How many people have heard of milestones? You probably have. It's a hot thing in the US and Canada, in the Netherlands and Australia right now. So a milestone is that thing that marks the progression of competence. It marks the different abilities along the spectrum, the developmental continuum. And if you think about it, you might have, say, starting up here, a milestone, another one, another one, another one. Finally, you reach this one here, and you're considered competent. So here's a couple of milestones as an example. The first says, describe to patients. I don't know what that says, but I'm going to do this. Is that correct?
Battery power.
Okay. You probably need to point it in there. The first one says, describe to patients common procedures of the discipline for the purpose of assessment of or evaluation of the patient. Maybe not quite. So that's the kind of thing, I hope it comes comes back. That's the kind of thing that I would expect somebody at a fairly junior level to be able to describe to a patient, well, you're going to have this particular intervention, this is what it means, and this is the kind of information that we get out of it. The second example was manage disagreements and emotionally charged conversations. Now, I know here that many people don't disagree, at least publicly with others, but being able to manage conflict is very important. I don't expect a junior medical student to be able to do it alone. I do expect a senior resident to be able to do it. So that's an idea of a milestone, one at the beginning of a series of a continuum and one towards the end of the continuum. Now, all of you have handouts, and I luckily have one too, so we'll just continue until we settle the technical problems. One of the things that we did when we developed our last CanMeds competency framework was that we decided to develop a series of milestones that were fairly general milestones. So we developed these milestones, we being each individual group for each domain of competence, and for each of the competencies within that domain and across from novice to expert, but we actually called it by the levels that we used before. Transition into discipline, core, to transition into practice. I'll wait until you get sorted out here. And that took about 2 years. It was a very interesting process. And we actually came up with a book. It wasn't a printed book, it's an e-book which you can get online, called the CanMeds Milestones Guide. Ah, perfect, thank you very much. Okay. I'll try and go down here. I think it's still loading. Came up with the CanMeds Milestone Guide. There should be 2 slides up. Ah, perfect, that's not there. Okay, good. Thank you. I think it was just thinking. Which is here. It was fun to develop. It took a long time. And here is an example of 2 sets of, this is the kind of thing you see in the Milestones Guide. Just to orient you, across the top are the stages of residency. From requirement to get into residency through transition, core, transition to practice, and I think that's advanced expertise. And I've given 2 examples, one from medical expert, which is recognize and respond to adverse events and near misses. So that's a patient safety issue. And so for a junior person, we'd expect them to really only be able to describe the scope and burden of healthcare-related harm. By the time they're in the middle of their residency, they should be able to respond to patient safety issues and disclose adverse events. And by the time they're an expert, they might even be teaching about it. Another example is from the professional role or professional domain of competence. And this is responding appropriately to an ethical issue in practice. And again, at the beginning, it's really just knowing about what the issues are. And towards the end, it's really responding appropriately to them. By the time you're an expert, you might be advising on complex cases. I want you to notice that not all of these have milestones in each section, in each place. And also, some of them have 2 milestones under one stage, and so it's not that there's a linear relationship. Some have 1, some have a few. So here we have this document that had a few milestones in it, but we ended up with a few problems. We have 6, I'm sorry, there are 7 CanMed roles. There's 6 around the edge and 1 in the middle. How could I make that mistake? Within those, there are 27 key competencies, which all have sub-competencies or enabling competencies, and we ended up with something like 1,200 milestones. And we realized that was too much, and so we edited them down to about 700. And, not surprisingly, there was some major resistance from the teachers and the educators, who, even before we'd released it, said, oh my. They said more than oh my. They said, this is reducing it too much. It's breaking it into too many parts. A doctor is way more than the sum of these abilities. And why are we aiming for just competence? Why not excellence? All kinds of things. So we said, well, what can we do? The milestones are very useful for curriculum planning. They're just not very useful for teachers, and may not be very useful for learners if you have 1,000 of them. Enter EPAs, or Entrustable Professional Activities. This is the newest term, and the last term I'm going to define today. So EPAs you also heard about from Dr. Lee a few months ago. She used them in a slightly different context, though. An EPA is an activity or a task that's important or essential to the discipline, which could be a profession or a specialty or subspecialty, that you or that an individual can be trusted to perform without direct supervision in a particular context. So an EPA is something that a trainee will have to demonstrate that they can perform competently before you let them do it by themselves. So an example might be manage an outpatient clinic in your specialty. Okay, that's a fairly senior EPA. I would expect someone to be able to do that before they go out into practice, but not as a fairly junior person. And we'll show how we fit these into the teaching in a minute. Here's another EPA. Prioritize a differential diagnosis. Take a list of problems and put them in order of priority. I'd expect a fairly junior person, probably a good medical student, should be able to do that. But it's still an activity that's necessary for the discipline. We have a little bit of, not disagreement, 2 options here of the way we look at EPAs. The first is that I have EPAs that go from simple to complex, like the 2 I've just shown you here. This one I would probably put at a senior student level and expect a student to be able to do that. This one I would put at a senior resident level and expect them to be able to do that. That's really the complexity of the task. The other way of thinking about it is the level of entrustment. I would not trust this trainee to do this at all. They could just observe me. I would trust them to do it partly, with my hands in there. I would trust them to do it as long as I was in the room, even if it was more distant. I would trust them to do it, and I'd be outside the room on call if needed. I would trust them to do it independently, and I would therefore consider them competent. So there's 2 ways of thinking about it when you're thinking about a learner. One is it a simple or complex task? And the other is, how close to them am I going to be in terms of entrustment? And both of these are in use around the world. It's a bit confusing, but I'll show you how it works in a minute. So EPAs really are made up of milestones. The EPA that we just looked at about the clinic, or say an EPA about performing a surgical procedure, would consist of some milestones having to do with the technical part of the procedure, probably a milestone in terms of communication skills, in terms of gaining consent from the patient, perhaps a milestone in terms of documenting the surgical procedure, of working in the operating room team. All of those would go into an EPA about performing, fixing a fractured hip or something like that. why do EPAs work? And by work, I mean, why are they effective in terms of the clinical teacher? Well, the first thing is that they're practical. They link with the clinical context, and a clinical teacher can recognize an EPA. They may not recognize a series of milestones, but they can recognize, this is something that I do every day in my daily life. And therefore, I know when I can trust the trainee to do this, because I've observed them. Clearly, they also contribute to patient safety, which is an issue, because you're not going to leave somebody alone if you haven't entrusted them to do whatever it is. They help in terms of assessment, which we're going to be talking about next time. But if you're giving feedback to somebody, there's a clear picture with the EPA of what you expect as a teacher and what the learner is supposed to learn as a learner. And the other important thing, given what I said 5 minutes ago, is there's not so many of them for each discipline and level. Whereas we had 1,000-odd milestones, if you look at most disciplines, they might have 8 or 10 or 12 EPAs for each stage. Maybe a few more if it's a longer stage, maybe 15, but that's not bad when you think a stage could be months or even a year or two. So they're much more manageable. I'll give you some examples of EPAs, and you have the list of them, but I'm going to just pick out a few. These are the end of medical school EPAs. They're used in both Canada and the US. They differ slightly in terms of wording. This is in fact from Bob Englander's, the US model, because the Canadian one is not official yet. But this is what a medical student in Canada would be expected to have attained by the end of medical school. Notice I didn't say do, I just said attain. They would be entrusted to, for instance, gather information, do a physical exam, come up with a differential diagnosis, recommend some tests, write it down properly and present it orally. Think of questions that they don't know about that they'd like to answer. Safely do handover, because day one of residency they're going to have to do handover, so it has to happen in medical school. Be a good member of a team, recognize when a patient is sick, obtain consent, perform general procedures. That's really vague, but it's things like venipuncture and things like that. And also know a little bit about patient safety so that they can identify when there are failures in a system. So those are fairly general. There are 13 of them. And along with some of the other goals of medical school, I think these are very reasonable goals. But let's look at it in residency. And what I'm going to do is give you 4 EPAs, one by one. And I want you to tell me, whether, by show of hands, whether you think this is an EPA for a fairly junior learner in residency, or a more senior learner in residency, or someone in the middle. So here's the first one. This is internal medicine residency, and the EPA is recognize an unstable patient and provide basic emergency treatment and seek help. So by a show of hands, how many of you think that this is an EPA that should be attained by beginning residents?
Do you think of the Japanese situation?
Okay, so by a first-year intern in the first few months. Would that be okay? That's
In Japan.
in Japan, yeah. So fair number of you, okay, some of you have.
Give us a chance to raise our hands.
Okay, that's fine, I will. It's interesting to know that some of the lay people here would like their doctors to be able to do this early on, which I think is important. Okay. How many of you say middle level, like beginning of specialty residency in Japan? And how many of you say not until you're a senior resident, almost ready to go out into practice? Nobody, right? So I think in North America, we would expect this to be very early on in the postgraduate training. You know, internship here, early residency in North America. Here's another one. Again, it's internal medicine. provide internal medicine consultations to other clinical services. I'll give you the three choices now, and then we can do hands. One is early intern, middle of internal medicine residency, specialty residency, end of specialty residency. How about early intern? Anyone? Middle of residency? Fair number of people. End of residency? A few more, maybe about half and half there. Interestingly, I think in our situation, we would expect a mid-level person to be able to provide a good consultation. Okay, here's another one. Facilitate transitions through the system. In other words, make decisions about when and where a patient who's ready to leave your care should go. That's what that means. And we'll do the same thing. Early internship, middle of internal medicine residency, end of internal medicine residency. So early internship, anyone? Mid-residency, okay, end of residency. A few more for end of residency here. And demonstrate an effective strategy for lifelong learning. In other words, being able to assess themselves, reflect on what they've done in clinical practice, use the literature appropriately, and commit to maintaining their learning. So same three levels now. Intern, mid-residency, end of residency. So all of them have to be done by the end of residency, obviously, but you'd like to be able to do a few of them earlier on. This one, in fact, we say to do the whole thing is really the end of residency. The transitions through the system, in fact, we kind of expect someone about our second year internal medicine resident to be able to do that, because they are actually running clinical services, so they have to make those decisions. Are you confused about milestones and EPAs? Because many people are. So here's how I explain them. Milestones are abilities. They're more detailed than competencies. They're clear statements. They talk about an expected level of ability along a spectrum. And they're observable so you can give feedback. EPAs, on the other hand, link those abilities with the clinical context, and they reflect a collection of different competencies or different milestones. That probably doesn't help you, but I suspect that this will. A milestone relates to the person. It's the ability of a person. An EPA is a task or an activity. And that's the big difference. The EPA is what happens in the specialty. It's what people do in the specialty. A milestone is a reflection of where an individual is at, a person is at any period of time. And they link together because EPAs consist of milestones or of some form of competency. So what we want to do is somehow or other sequence the teaching and learning. And I'm going to give you again an example from Canada. Here is theoretically that those levels of training that you saw in the diagram earlier on. And in here we have a whole series of milestones, of EPAs, and of some milestones as well. And what happens is you go through, say, your transition into the discipline, and you attain all of those EPAs, you're checked off, and you're ready to go on to the next stage where you attain the EPAs and some milestones that don't have EPAs, and so it goes. Okay? And there aren't as many of these as there are of milestones, and so it's manageable by the program directors. What if the resident or student, it's usually a resident, has a problem? They're not able to attain the EPA. Well, if they don't have a problem, it's easy. They've successfully completed it. They move on to training in the next one. They still have to maintain their competence or their ability in that one, so it doesn't mean they can walk away, go on holiday, and leave the service. But they're fine to go on to another one. If they haven't, you can look underneath the surface of the EPA and find out what milestones are there. We talked about how milestones fit with EPAs, and that may help you as a clinical teacher figure out what the problem is. You unpack the EPA. You review the milestones, and so you can appropriately address what the problem is. Is it a communication skill? Is it a knowledge problem? Is it a technical problem, an attitude problem? I'm moving on. We've talked a little bit about how to set up a curriculum, and I've given you some examples from Canada. Now we're going to talk about using innovative teaching strategies in this context. And this context implies that there are some changes of teaching strategies, that there are fewer of those 4-hour lectures. For medical students, it would be an increase in problem and case-based learning, early clinical exposure. Both of those are things that expose the learner either to paper cases, simulated cases, or real patients. Also, that we get them to learn actively in groups, perhaps from their peers or near peers, and that we consider using a flipped classroom model, which I'll describe in a minute. What it also means that there's fewer lectures, probably shorter lectures, and that learning objectives are replaced by milestones, EPAs, or outcomes. In the clinical setting, it means that the learning experiences are assigned specific EPAs, and direct observation and feedback becomes very important, as does coaching, boot camps, or simulation techniques that are a bit advanced. And I'll talk about all of these briefly. Let me give you an example, first off, of this, learning experiences with assigned EPAs. And I'm going to use one that I know well, which is the setting of an outpatient clinic. Okay? Residents are assigned to the clinic, and one way of thinking of it is I should maybe make sure that they all see a patient with a heart problem and a patient with a lung problem or whatever. That's impossible to do in the clinic. But what we really have are some EPAs that are level specific. For a more junior resident is to diagnose and manage patients with chronic conditions in internal medicine. A little bit more senior, they're providing consultation on new patients. If they're the internal medicine fellow or the very senior subspecialty trainee, perhaps teaching junior residents is important. And for those fellows and senior residents, being able to manage the clinic is important. I would not expect a junior resident to be able to manage the clinic, maybe just their own time. So if you look at some of the milestones involved, some of them are things that I expect everyone to have. Not just the junior residents who will have to learn how to gather data in a time-intensive setting, communicate properly, appropriately create problem lists and management plans. I expect all of them to be able to do that. But I'm going to be concentrating on that for the junior resident. And for the more senior people, perhaps communicating, where are we here, with the referring doctor, collaborating with the healthcare team, the clinic nurse, or the pharmacist. I'd like them all to use evidence, but I would expect the very senior residents to be able to demonstrate this for me, as I would expect them to be able to demonstrate teaching. I would like them all to be able to manage time, but I'd like the senior residents to be able to manage the time of their more junior colleagues, and deal with things like scheduling issues. So this is how, in an outpatient clinic, I can have residents at a number of levels, and students. I would actually include students in this part here. Have them all seeing patients, and have them all learning something that's level appropriate. I wouldn't put an EPA in here on diagnosing a severely ill patient. It might happen in clinic, but the chances are that's going to happen in another place, like the emergency room or on the ward. So that's where that EPA would go. I'd like to talk about a couple of other instructional strategies. I'm missing a slide here. Hang on one sec. I guess not. Okay. I'd like to talk about another couple of instructional strategies. Flipped classrooms, boot camps, coaching, and a little bit about some advanced simulation methods. So, how many people have heard about the flipped classroom? It's a hot thing in education these days, and is moving into medical education. So traditionally, what happens is you go to class and you have those hour or 4 hour long lectures, and a lot of stuff comes in, a lot of facts come in. And then you go home and do homework, which could involve applying these facts or using these facts in some way. And a flipped classroom changes this by having the content, the facts, delivered outside the classroom. I don't know whether you can see that here. Yeah, it says at home here. And what happens in class is the analysis and application and synthesis. So usually there's either online or sometimes paper-based assignments that have to be done before the class, and then the knowledge in the content is not reviewed in the class, it's applied, usually by using cases, sometimes by using quizzes to make sure people, and discussing them to make sure people have actually learned. So if you think about it, for a medical student, case-based learning can be structured as a flipped classroom. Student can go home, they can read whatever the basic knowledge is around the case. They can even read the case, but when they come to class, they then discuss the case and the application of knowledge to that case and how it would be used. The class time is used for discussion and not for lecture. It can be spiral. Spiral meaning you learn something out of class, then in class, and you go home and learn some more, and then apply that at a higher level in class. So you're increasing your knowledge. The challenges are, at least at our place, the same as the challenges are here, because I've heard about them. The students aren't motivated, they don't do their reading, they're not willing to complete things before they come to class, and anyway, my teachers don't know what to do. So they revert to lecturing, because it's easier. And the students are quite happy to do that. They feel their role is to listen. So it's not without problems, but if well done, a flipped classroom can work even at a fairly junior level. And if you were a medical student, wouldn't you, or a physio student or a nursing student, wouldn't you like to not only learn the basic science but learn how it links with clinical medicine, even as a junior learner? Because that's what you're going to be doing with your life, is doing clinical medicine. Let me give you 2 examples of flipped classrooms that we have in use right now, just for fun. One is in our residency program at McGill. What we used to have was what we called a resident half day. Every Thursday afternoon, all the residents at all levels went to a classroom in the hospital, in all of our hospitals, and they either had a face-to-face or video conference lecture or series of lectures from the experts in the field on a curriculum that rotated every 2 years. So it was all of the stuff they needed to know about internal medicine and its specialties. Residents didn't really come unless we fed them, and they weren't too excited by some of this. And the other thing is, we didn't know whether they really were able to understand and apply what we taught them. So what we're doing now, and it just started this year, is having a flipped half day. Lectures, in fact the lectures from last year were videotaped and were available online. Supplementary material was also available online. And the residents are expected to have read this and looked at this before they come. This is done before the half day. And then the half day is used for case discussion, small group work, etc., to ensure that the residents get a chance to apply and use what knowledge they've got at a higher level. So far it's working. So far the residents love it because they can see the application of it. And we're in the middle of a study to look at the effectiveness. I'm sorry we don't have that right now. We do, on the other hand, have some results from a study done on this half day. We think of flipped classrooms as only useful for clinical stuff. But here's a flipped classroom that was used to help residents learn how to be good role models. We have a residents as teacher program. Residents can come to this, and it usually involves an introductory lecture and then a series of modules done in our simulation center on feedback and giving a good lecture and teaching in the clinical setting and learning how to teach a procedure, all those things that residents need to know about teaching and faculty members. We wanted to do something on the resident as role model. So our flipped classroom meant that residents who were going to do the role modeling module looked at an e-lecture, very short one, about role modeling, and then did a reflective exercise. And all of that provided the residents with some background information. They then came to a workshop, and in that workshop, they had simulation scenarios, basically. Two actors and a resident in the simulation center with a debriefer and some other residents outside. And there were a series of these that happened over the course of 90 minutes. As usual, the debriefing was at least as important as the actual doing the scenarios. And the role modeling was in one case somebody role modeling appropriate communication skills, and the other was role modeling health advocacy. At the same time, they also got a little card with some of the key actions for an effective role model. This has been proved effective, at least from the perspective of confidence. Residents feel much more confident, and they at least report using those actions for role modeling more since they've done this. So here's where a flipped classroom has been effective. The next and almost the last thing I'm going to talk about is coaching. And it really uses Erickson's model of deliberate practice, which here you can see one of the Williams sisters, tennis coach, using. I put this in because it's the time for the Australian Open. Coaching, we all know about coaching. We probably do it, but we don't realize we do it. What I'm going to suggest is that by using milestones or EPAs or the learner assessment of where they are, we can observe a learner do something, look at what they've done, provide some feedback, set some goals, and continue to do that, and eventually get to the point where, as a coach, I can provide a summative assessment. But really now we're talking about teaching and learning, so it's a formative assessment. I think we use this in the clinical setting all the time, frankly. I think we use it when we watch a resident do procedural skills, or when we watch a student do part of a history or physical on bedside rounds. We listen to them present a case report, where we listen to their reasoning skills, we observe their professionalism, we observe their time management, or we even look at the work they're doing. We observe their written work. And we coach on all of these things in many settings. We probably don't realize that it's coaching, but it's very effective usually. What we need to improve is that direct observation and feedback, because many times we get to the ward or the emergency room, and especially for a senior person, they've done the job. So we talk to them briefly and then, okay, next patient. Whereas we should be spending some time either listening to their reasoning skills, observing their interaction with the patient, or looking at the written work. There are some tools to help us with this. And I'm not going to talk about them now except to mention them: mini CEX, professionalism, MEX, the procedural skills ones like OSAPs and DOPS. All of these are tools that help break down and observe parts of what we're talking about here. So I think we do it, we just need to do more of it. Boot camps. Does everyone know what a boot camp is? It's used in the military. You send all these raw recruits in and some nasty sergeant yells at them for 6 weeks and makes them into Marines or soldiers or whatever. But in fact, it's very helpful to use in medicine if you consider particularly that we're getting trainees who may come with varied levels of knowledge and skills, and they're entering a new clinical role. It's very useful at that lower transition into discipline stage. And boot camps have been shown to be effective educational strategies, both from the skills that people learn, the knowledge they get, and the confidence they have when they go out. I'm going to give you an example of a boot camp that I was involved in. It's not in internal medicine, but I was working with a colleague in anesthesia. In anesthesia at our university, for the first month of residency, all the residents spend alternating days in the simulation center and on the ward, in the operating room, I guess. When they're in the operating room, they're linked to a senior resident who acts as their mentor. And I'll show you the boot camp, what it meant, but I can tell you that the result of the boot camp was a significant increase in preparedness and in confidence in terms of technical and non-technical skills. So this is what it looked like, and it used that last thing that I was talking about, advanced simulation methods, complex simulations. There were a number of goals ranging from knowledge acquisition, decision-making, crisis resource management, procedures, professionalism. And for each of those, there were a number of teaching and learning methods. For online learning, quizzes, high-fidelity simulations, standardized patient simulations, procedural skill trainers or task trainers, all used appropriately. So for the communication skills, they use standardized patients to have the anesthesia residents learn how to consent to patient. For crisis resource management, they use the magic dolls that can do everything and that you have to intervene on. So complex simulation methods. The interesting thing was this was one day doing one of these things, one day in the hospital, next day simulation, next day in the hospital for a whole month. And very intensive, but at the end of it, all of the trainees were at not only at a higher level, but all at pretty well the same level where they could be entrusted, goes back to that word entrustment, to do some of the basic things that are necessary for an anesthesia resident when they first start out. The nice thing was that they also had their buddy, their mentor, a senior resident, who showed them what to do when they were in the hospital. So they weren't left on their own in the hospital. So I think this is a nice example of a boot camp. Talked about a lot, haven't we, in the last little while. What about some implications for Japan? I think there probably are some, both in terms of curricular planning, teaching and learning, and thinking about accreditation. And I just make these as humble proposals. But I will suggest again that developing a competency framework which runs across from medical school into practice would be really cool. And I think you could probably do it here in Japan. From what I understand, it would be possible to do. You would be only the second country in the world to do it, so you'd be a leader in the world if you were doing this. I would encourage you to use competencies and abilities as outcomes, not just in residency, but also in medical school. There are lots of frameworks you can use for this. And to move to more active strategies with less lecturing, more mastery learning, more learning in the clinical setting. And I would remind you that accreditation, which wasn't around when I was here 10 years ago, is very much around now. They're already looking for curricular change and teaching innovations. And in fact, if you look at the current cycle and look at the things in pink, that's what basically the accreditation surveyors are looking for. So they're using a similar kind of cycle to what I'm proposing for curriculum planning. They're already using that when they evaluate how good or not your medical schools and residencies are. So what have I been talking about? What would I like you to remember? The goals of a curriculum could be or should be derived from the abilities that are needed by graduates, which in theory should come from what society needs. They can be organized into frameworks, developed into steps and sequenced. Milestones and EPAs allow you to do that fairly simply. Teaching and learning can be logically sequenced according to these goals and according to the type of teaching and learning strategies. They can be linked to specific settings. You can say, I'm going to learn this EPA in this setting. And it's likely that some of those teaching and learning strategies that we've talked about, which are innovative, will help to improve competence. So I'll stop there, and I'll ask if there are any questions. Thank you.